AI companion, you can also start. Yes, we are all set now. Good evening, all of you. Welcome to this 260th edition of Thursday Musings. Today we'll be talking about premature ejaculation from a person who is a total expert in this field. We have a psychiatrist and a urologist chairperson to complete the spectrum. Welcome all of you. The meeting will be recorded. This will be put on the YouTube for later viewing. The questions are invited in the chat box. So you should type the questions in the chat box, which will be put up to the presenter. So next slide, please. Now I'm handing over the session to the chairman of this program. Next slide, share. Welcome, Dr. Professor Tofan Pati, sir. Over to you, sir. I'm not reading your slide. Over to you, sir.
Yeah. Thank you, Dr. Alim. And thanks all the participants for joining this program. And next slide, please. We have got with us vibrant moderators, Dr. Amrit Patidossi. We expect him to join sometime soon. And Dr. Alim Siddiqui, Dr. Bisal Chabra, and Dr. Shobit Garg. They are all vibrant as always. Our moderators are Dr. Manmeet Singh. He is a neurology, robotics, and kidney transplant specialist who is having more than 20 years of expertise. He has pursued his MBBS from LLRM Medical College, Meerut, MS General Surgery, GSB Medical College, Kanpur, and MCH from Department of Urology and Renal Transplant, SGPGIMS, Lucknow. He is trained in robotic urology surgery and a pioneer in starting cadaveric kidney transplant in North India, and started organized life-related kidney donor program in Lucknow private sector. Dr. Manmeet is a member of Urological Society of India and the Association of Surgeons of India. He provides multiple services to his patients, such as female urology, urinary incontinence and genitourinary fistula surgeries, lap sacrocolpopexy, TVT, and TOT. Pediatric urology, including hypospadias, urethral stitch surgery, DVIU, buccal mucosa graft urethroplasty, and PFUDD repairs. Management of all urological cases like prostate, kidney, urinary bladder by minimally invasive and robotic surgery. He has also experience in laser surgeries of stones in kidney and prostate with male infertility and male sexual health related problems. Welcome, Dr. Manmeet Singh. Next slide, please. Dr. Mohammad Abrar Guru from Kashmir. A senior consultant telepsychiatry telemanus at IMHNS Kashmir. He is ex-lecturer Department of Psychiatry, GMC Srinagar. He is MBBS from Dhaka University, DNB Psychiatry from Atma Institute of Mental Health, Tiruchirappalli, Tamil Nadu. Field of interest, community psychiatry, digital psychiatry, and psychosexual medicine. With this, I hand over the meeting to the chairpersons. Please carry forward. I take this opportunity to raise a good and happy observance of World Mental Health Day tomorrow, along with Kadwa Chauth. Welcome everybody, and over to the chairpersons. Dr. Abrar will introduce Dr. P.S.S. Rao, and both will introduce the topic. Over, please carry
on. Thank you, sir. Good evening to everyone. It's my pleasure to be a chairperson in this session. To my one of the favorite teachers and favorite teachers of all of us throughout the India, who has an expert review and expert knowledge regarding the psychosexual medicine, Dr. T.S.S. Satyanarayan Rao, sir. Good evening, sir. Sir is a professor emeritus in psychiatry and chief coordinator in psychosexual medicine, Department of Psychiatry, JSS Medical College, JSS AHER, MG Road, Mysore. Sir has been immediate past secretary, Indian Psychiatric Society, editor of Journal of Psychosexual Health, President-elect South Asian Societies for Sexual Medicine, affiliated to International Society for Sexual Medicine, former President, Indian Association for Geriatric Mental Health, former editor, Indian Journal of Psychiatry, co-chair Psychiatry and Human Sexuality Section, World Psychiatric Association. Publications, sir has numerous publications, more than 349, book chapters, more than 26, award and orations, including Marfatia, DLN Murthy Rao, C.V. Raman Distinguished Scientist and Acharya Awards. Sir is president Karnataka Sexual Science Academy. So we all of us know sir. So I don't think any one of us needs an better introduction or information regarding sir. Sir has been teacher to all of us, and with this important topic that sir is going to deliver on today, from a psychiatry point of view, I can say that it is very important to understand the sexual side of a male or a female, which is very important in relationships, in personal health, because one of the pillars of our existence is sexuality, and we most of the times focus on our sexuality, whether it is good or not. And premature ejaculation is such that it can lead us to unhappy lives, unhappy sexual lives, unhappy marriages. So none other than sir can deliver on this and guide us and teach us better how to deal it and how to go ahead with this. So I thank sir to deliver on this and elaborate and educate us on this. To my co-chair, Dr. Manmeet.
Yes,
Manmeet,
sir.
if you want, you can say a few words about the topic.
Sir, thank you. First of all, I'd like to thank Dr. Aleem Siddiqui and distinguished teachers in the group, especially Dr. Rao. And even I am, as a urologist, quite eager to know more about premature ejaculation. I feel most of the time the first contact of a patient of premature ejaculation is to a physician. Then he refers, once the patient is not satisfied with him, he refers him to a urologist, and the cycle goes in a way. When urologist, as a urologist, I cannot treat him well, I send him to the psychiatrist, to my psychiatrist friends. So I believe it is a complex task treating a patient of premature ejaculation. And as a doctor, we have a huge responsibility, because as told by Dr. Abrar Guru, it involves a lot of interpersonal relationship between a partner. So like we need to treat this problem seriously. And just like any other disease, this disease is a very important thing for that particular patient. So in my practice, what I have felt, we are only partly equipped with that power to treat the patients, because we believe we treat those patients only by medicine, and medicine is only 30 to 40% part of the treatment. Along with this medicine, so there are so many other things which need to be given to that patient so as to get a good treatment for that patient. So I think that my psychiatrist friends play a very important role in treating. And today I am blessed ki I am in this meeting, and I think I learn a lot from all of you about treating premature ejaculation, and I'll try to share my thoughts how I treat my patients of premature ejaculation. Thank you.
Thank you. Rasa, you can start now. You can unmute.
At the outset, I am really grateful for this wonderful opportunity that has been provided to me. Congratulations, Thursday Musings, for world record-breaking programs consistently happening, and almost this is one of the occasion where I keep myself totally free for something new. Almost always we can expect from this program. I am grateful to Abrar and Manmeet for very nice things what they have spoken to me. And today's topic, premature ejaculation, is so common, so frequently spoken in almost many of the branches of medicine, whether it is physician, urologist, psychiatrist, gynecologist, and sexologist. This is one of the very frequently used terminology. And when I say psychiatrist, if there is one sexual problem which primarily and predominantly belongs to the domain of psychiatrists, this is premature ejaculation. Why and how I'll come 1 or 2 minutes later. But all said and done, this is one of the most common, frequently encountered problem in any clinical practice, particularly so as far as sexual medicine practice is concerned. This is a very broad area. Say when we say something like somebody is having fever, it is almost equivalent terminology. Premature ejaculation is more a syndrome rather than a specific problem, as far as the current understanding is concerned. One important thing people have documented is that when you are trying to talk about ejaculation and issues related to, one is what is normal to consider. And there is a whole spectrum related to this. One is premature ejaculation, which is extremely common condition because of some of the epidemiological studies quoted so. Delayed ejaculation leading to anejaculation or retrograde ejaculation are not our domains. Dr. Manmeet is there, and urologists, endocrinologists, andrologists, and many people deal with this. And from that particular angle, very rarely I may be just touching upon some of these points. Otherwise, for all practical purposes, my presentation would be confined to what we basically call as premature ejaculation and issues related to that particular area. Let me start. See, when we say ejaculation, it is the outcome of sexual arousal and occurs gradually with orgasm. So you look at this particular term, gradual. Some people believe this is something gradual too. There are other definitions which talk about it occurs simultaneously with orgasm. To be very bluntly and maybe in a little bit of crude way, what happens between the legs is actually ejaculation. What happens between the ears is actually the orgasm, or what we basically call the whole issues which are related to this process of ejaculation and why this happens. We're all well aware of Marston Johnson's work, and then subsequently the work by Kaplan and quite a few people. All of them have documented that there is a desire component which is absolutely necessary. Penile tumescence happens, erection and penetration, and ejaculation with orgasm, what we spoke 1 or 2 minutes ago, and post-ejaculatory detumescence. So this is actually one of the process which has been very well documented. But what goes wrong as far as premature ejaculation concerned, there are many aspects, and to keep it a little lighter, I have added 1 or 2 visuals here for the simple reason that it becomes easy to understand. One important point is actually, in case of premature ejaculation, the plateau phase, what mentioned by Marston Johnson's, is of a short duration. There is a steep excitement and there is a short plateau, because of which what would have happened properly is not happening. What it means is sex is actually a process necessary for partnered sexual activity. And as far as men are concerned and women are concerned, there is actually a difference. Men are usually faster on the gun, and this is one of the reasons why in some individuals this happens a little faster. What is normal and what is desired is one of the area where people have made a lot of effort. And one important point what I can tell is one of the rough diagram, but tells very vividly what precisely happens. In case of man, around 2 to 3 minutes, very fast they get aroused. And one of the important point what actually has been mentioned is men are tube lights with so many aspects are concerned. But when it comes to sex, they are like candescent bulb. They get aroused very fast. They are fast on the trigger. As far as the women are concerned, in fact, stream is three. In fact, what one can say is put the plug on. It takes its own sweet time to heat up. And then, in fact, the whole process happens in some particular way. We'll come 1 or 2 minutes later. So this difference between these two and this particular point only what actually necessary for understanding premature ejaculation is the time-honored terminology because of which this has been retained, but all in fact, the DSM classification uses the terminology early ejaculation. And there is an explanation why and what actually is necessary. As far as the men are concerned, I just thought one or two small videos I'll just play. Marshall Johnson's documented. Very fast trigger, early ejaculation can happen. And in fact, women as concerned, they take their own sweet time. But once they have reached a particular level, they could be multi-orgasmic. Though this has been documented in laboratory situations, one of the current understanding is that females can experience multiple orgasms. And it is also possible they may not experience orgasm at all. So the whole issue is the refractory phase, which is actually very common in males. Very early age, it may be a little different from very elderly, but this refractory phase, which actually makes so much of difference because once ejaculation happens, he is not able to get ready. And why in partnered sexual activity, what Marston Johnson was mentioning about these physiological changes which determine, when we try to look at female sexuality, the issues are something totally different and they need time. And the whole range of processes in poetic terminologies, what David Reed mentions, seduction, sensation, surrender, reflection, these are all, in fact, what we basically call they need time. So what is desired is, instead of erection happening fast, ejaculation happening early, how it can be delayed and which can match actually the other partner's responsiveness is one of the whole issue. So one is already finished, but other person is actually now they are starting and leading to what we basically call significant problems in what we basically call sexual responsiveness. Majority of the studies are there which actually document that the time duration necessary, it may be starting from 5.4 minutes to 6 minutes. This is the time majority of the population actually moves around. There are actually a lot of historical aspects related to this. For example, it is a neurosis linked to unconscious conflicts, what was actually the whole range of psychoanalytical explanations which were available at one time. The Shapiro's P is a psychosomatic disorder. William Marston Johnson is a behavioral disorder. And Marcel Waldinger, the most current one, actually the lifelong PE plus other subtypes, what he documented. Each of these things. This needs very elaborate description, and I'll come 1 or 2 few minutes later to that particular area. What are the definitions? In fact, I could just call out somewhere around 40 to 50 different definitions related to what we mean by premature ejaculation. What Marston Johnson mentioned was a man has PE if he is unable to delay his ejaculation until his partner is sexually satisfied in at least 50% of their sexual approaches. But look at what we were trying to talk about a few minutes earlier, that there are actually females who don't reach orgasm at all. We did one of the studies wherein, say, for example, masturbation as one of the criteria. Western studies talk about 60, 70, 80%. The Indian population, the reported figures from our study was around 32%, of which only about 12% were reasonably comfortable. And all female inhibitory sexual responsiveness treatment is directed by what we call masturbatory training. If you look at this particular data, almost majority of the women, hardly they have any knowledge or idea related to what is orgasm. So one maybe actually gets labeled as premature ejaculator because it is actually partner's problem. Helen Kaplan talks about premature ejaculation occurred if a man didn't have voluntary control over when he ejaculated. That means he wishes and whether this particular capacity he can actually get it. There are multiple other earlier diagnoses to be based on 1 minute, 2 minutes, 3 minutes, 7 minutes, and number of strokes. Many other such things actually people used to talk about. Less than 5 strokes. This was one of the definitions, but all of them were what we basically call arbitrary definitions. Ejaculation with minimal stimulation and earlier than desired, before or soon after penetration, which causes bother or distress, and over which the sufferer has a little or no voluntary control. This is one of the very broad definition which actually the ICSED actually came out international consultation related to premature ejaculation. And Australian guideline talks about premature ejaculation is ejaculation that occurs sooner than desired, either before or shortly after penetration, causing distress to either one or both the partners. So there are three components involved. I'll come 1 or 2 minutes later. Just to give very briefly some idea that are different. So International Societies for Sexual Medicine talks about ejaculation within about a minute, inability to delay ejaculation, all or nearly all vaginal penetration, this is happening, and negative personal consequences. World Health Organization ICD-10 talks about inability to delay ejaculation, sufficient to enjoy lovemaking, ejaculation before or soon after beginning intercourse. Australian, we have already mentioned 1 or 2 minutes back, inability to control ejaculation for sufficient length of time before vaginal penetration. American Psychiatric Association talks about, of course, 1 minute. DSM-4T, at that particular time, the 1 minute time was not the point. Persistent recurrent ejaculation, minimal sexual stimulation before, on, or shortly after penetration, and before the person wishes. So what I am just trying to give is, there are multiple things are there, but 3 important things. I'll come 1 minute later again for that. Premature ejaculation is the inability to delay ejaculation sufficiently to enjoy lovemaking, which either manifests as the occurrence of ejaculation before or very soon after beginning of the intercourse. Or DSM-4, persistent or recurrent ejaculation with minimal sexual stimulation before, upon, or shortly after penetration, before the person wishes. So there are 3 important components. Premature ejaculation is defined in DSM-5 as a persistent or recurrent pattern of ejaculation. Second point, what we should remember is, during the partner's sexual activity. This is the punchline. Many people actually miss it out, which I am going to talk about a little later again. But the important message now itself I would like to give is, say, for example, very recently a diabetic and having erectile dysfunction, one of our postgraduate presenting this as both PE plus ED. What is this thing? He is having sexual intercourse once in a month or once in 1.5 months, and he has early ejaculation. That should not be the case, which actually should be labeled as premature ejaculation at all. Within about 1 minute following vaginal penetration, and the last one before the individual wishes it. If you look at, these are the 3 important points which are necessary. And once in a way, this can happen. I'll come to that. 6 months, if it is consistently, regularly happening, then only this particular diagnosis should be made. For example, ICD-11 talks about many things, and this is one of the most progressive definition for ejaculatory dysfunction, HA03 plus subcategories. And one of the most important problem currently, what we have is actually what we talk about, the time duration, which has been actually latched on to by DSM-5 classification. A serious disadvantage of DSM-5 is that 1 minute criterion is used for both lifelong and acquired PE, and that a third PE subtype is not mentioned. What is this third PE subtype? This is the Waldinger's classification. I'll come on 1 or 2 minutes later again. There is no specific scientific reason for this illogical position. The continued use of 1 minute cutoff point for all subgroups of PE ignores the existence of acquired, or in fact the subjective PE systems, what actually very commonly. This is the Waldinger system. What it talks about is lifelong and acquired PE. This is what primarily what we talk about, premature ejaculation, and one should understand that. But if you look at the epidemiological studies, plenty of the cases were labeled as PEs because they were following what we call the loose criteria, and the natural variable PE. This can happen in any individual's life, time to time. 2, everybody wants to perform it for a longer time. Premature-like ejaculatory dysfunction. This is what Waldinger mentioned, and this needs a detailed elaboration related to this. So there are few dilemmas what we have as far as premature ejaculation is concerned. So very few men, their partner or even physicians know what is normal. Shortly is a relative term. Absolute measurement of intravaginal ejaculatory latency time by stopwatch, preferably female partner, is required. But in our country, there is a lot of difference related to this. Identifying control and or distress component is more important. Some relationships have adjusted to the condition and have no dissatisfaction with the distress, don't label them. In some, a source of discord that extends beyond bedroom. But most important thing is age, novelty, situation, frequency, and many other such things actually determine. And one should almost always be very clear about what actually is this. And limitations in definitions have made research in PE difficult, as men with PV are not homogeneous group. It is a very broad terminology which talks about many things. So one should be very clear about it. Just to give little this thing. See, earlier one of the divisions used to be the Shapiro's very rapid ejaculation type B and type A rapid ejaculation, which develops later. God pontiffs type B and type A as primary, and other one is actually as secondary, which is not included there. And currently Waldinger, what I was trying to talk about. This is just to give an example. See, a same individual, in one situation, he may last for a longer time compared to a situation where there was a gap, there is a new partner, excitement related, whole lot of other such things which can determine. So it is very difficult to make a diagnosis unless one gets adequate information. Somebody is used to daily sexual intercourse, even if he gives a gap of a few days, in fact, he may have ejaculation much earlier. And gynecologists, for that matter, in fact, they want to do the semen analysis and all of that. They request the people to give gap of 5 days, 7 days, and all, what actually may actually help actually in what we basically call easy to masturbate and get the semen sample. But all said and done, this difference people have documented and it is well recognized. So how does one define premature ejaculation? So to one of the important point is inability to delay ejaculation. He cannot held back at least for 60 seconds after intravaginal containment. He has no control. He is overly concerned with ejaculatory control. And see, for example, none of these things are meeting, but one of the important reason why we actually take up some of the cases for treatment is when couple decides that there is a problem and they want correction of this particular thing. So to cut short ejaculatory latency time, poor control over ejaculation, a negative impact on quality of life are the three important criteria which are actually necessary to be kept in mind. You are early is one of the very common parlance in many situations to what we basically call corporate and such other area. Whether this is seen by patients in one way, partners in another fashion, and we therapists in another different fashion. These are all, a lot of such issues are there. Women see it as a selfish behavior and that this particular fellow is having no control. It engenders sympathy. P says he's selfish. Bam, boom, thank you, madam, is one of the important criterion. And in fact, I have been left high and dry is one of the major women actually talking about. And some people may compensate and overcompensate. See, one of the important thing is actually what is this overcompensation? I'll come a few minutes later again. It is not just a problem to mainly has to do with man's control over ejaculation and sexual satisfaction. There are a lot of other because it leads to consequences. Many women actually blaming the partner for the simple reason that you are so good in so many things, but you are absolutely, totally hopeless as far as bed is concerned, is one of the very common this thing. Men get disheartened. Whole range of anxiety, depression, and other related things actually have been spoken. But there is another picture. Do you suffer from premature ejaculation? In fact, husband, no, I don't, but she suffers. So man can suffer. It is possible. In many of the situations, women suffer because they have not been able to get the required satisfaction or the required stimulation in a situation like this. It has also been documented that both feel terribly upset and lead to quite a bit of difficulty. And some people actually claim themselves that I can be great because I am a premature ejaculator too. In fact, it is okay. Both of us not interested in this particular aspect at all, your timings, but we are happy that both of us are this thing. So what I am trying to convey the message is different couples, different approaches, and different consequences, which has been documented. What are the other consequences? In fact, this may be the cartoon related to ED, but it brings to one of the extremely important things that men showing any interest in anybody and made him disheartened by the partner. But this man, allow me to introduce my erectile dysfunction. Her name is Margaret. That means the role of partner in this. Extramarital affairs and lot many other things people have documented. It may be in terms of the man or also equally in terms of woman, because this is one of the important problems. It has been documented that is actually more common among those people who are used to porn, and there are a lot many other related things, starting from financial, education, and lot many other things. People have documented that this particular area could be a problem. How therapists use dysfunctional individual, either the dysfunctional couple. ED is misdiagnosed as premature ejaculation many times. This is what actually I was mentioning actually, because in a diabetic, infrequent sex, this may be. So regular partnered activity, regular and partners, these are the two things what we have to keep it in mind. P is not associated with organ system pathology. See, if there is any one condition where his system is actually little fast on the trigger, but for that, there is no documented any organic systemic disorder as far as premature ejaculation is concerned. This is one of the reasons why we all psychiatrists, we are the major people who are supposed to attend to this particular problem as our domain, and extremely important for this. Urologist is here and he may be having a different idea, but let me tell you, if somebody presents with PE, he hardly need to be evaluated for anything else, because we already know that this is actually associated with the individuals being actually a little faster on the trigger. P is mainly a quality of life issue. Somebody is having ED leading to premature ejaculation leading to ED. This has been very well documented. Diabetes and other systemic disorders, starting from hypertension to, in fact, to name anything. In fact, many people have PE associated, but this particular PE may not be necessarily the very definitive PE. Endocrinologically speaking, the testosterone, thyroid hormone increase. In fact, these people may actually have early ejaculation compared to the prolactin, which actually delays. And whether it is responsible for infertility, this is one of the area many people, absolutely not. But all said and done, there is a PE of a certain degree that even before penetration, individual is having ejaculation. These are the people who may actually need to be kept in mind. There are two processes which urologists are here to explain to us. When we are trying to talk about physiology of ejaculation, there is something called as ejaculation and what we basically call emission. These two things, once emission up to that particular level an individual has reached, it is not possible to delay. So I was trying to talk about three important areas where there could be problem. One is ejaculatory latency, which is low. Individual has no control over ejaculation and leading to what we basically call the lack of sexual satisfaction. So these are the three important components should always be kept in mind when we are trying to talk about what we call diagnosis of HE. And when we are trying to talk about premature ejaculation, I was talking about Waldinger's classification. He comes out with the 4 varieties, lifelong PE, which is present from the beginning. And lifelong PE, for all practical purposes, these are all individuals with high degrees of what we basically call anxiety and other related disorders. Acquired PE, it was all right for some time, and then subsequently it developed. It could be anxiety, it could be depression, it could be many other things possible. Gap, that itself. Natural variable PE, what actually it talks about is, depending on the mood and context and lot many other things, there could be actually difference, and it should not be labeled straight away as actually premature ejaculation. It could be the better term, in fact, what we talk about early ejaculation. Premature-like ejaculatory dysfunction, what it actually, these 3 and 4, which were introduced by Waldinger, it has actually made topsy-turvy the whole DSM-5 system of classification and diagnosis of this particular condition. What it means is, he may be lasting pretty length of time, but all said and done, he wanted it to be last little longer than what it actually is able to succeed. So whole lot of people get into this particular picture. When we are trying to talk about epidemiological studies, these are all related. As one of the joke, I just added this particular photo. One of the patient coming and telling, sir, I felt very bad. The joke here is this way. Let me put it as a form of a joke only. Wife married for almost around 10 years. One day, suddenly she was there in the kitchen. She called him for having sex. And he went there and tried to perform. And then subsequently started getting doubt, never called for me to have sex in the kitchen, but why she called me this particular time. The whole problem was the visual of that vacuum pressure cooker was not working, and you don't last more than 1 minute. That's why I just called you to actually time it. It may look like a crude joke, but all said and done, these are all, in fact, many of the type of sufferings many men actually go through. Whole varieties actually people have documented how common each one of these particular syndromes. Let me not go into too many details. The important point is many of the treatments and many of the drugs what we talk about, they belong to this first category, lifelong and acquired. This variable and subjective, where primarily and purely non-pharmacological treatments which are actually effective among these individuals. So each individual establish presenting complaint, just go through either clinically or in fact by intravenous ejaculatory latency time, what actually they report, perceived degree of distress, on-chest duration of the PE, psychosocial history, medical history, physical examination. These are all extremely important to establish. So lifelong and acquired, they belong to a different category altogether compared to subjective and variable PE. There are plenty of studies, say starting from 4% of the individuals to 42%. That means the whole population can be divided into who are premature ejaculators and those who are not. But this particular extreme degrees of reportage is attributed to the fact that they have not used very specific diagnostic terminologies. Now what we know, many of the people less than 1 minute definitive PE, but they last much more than that. Say up to 1 to 1.5 minutes probable PE according to this DSM system if we go by. Incidence 4 to 39% as you are trying to talk about. An increased susceptibility to PE in men from Indian subcontinent has been documented according to some other studies. But if you try to look at the data, it is similar across countries. Say starting from somewhere around 23 to 29% in majority of the countries, the same story actually goes. It is consistent across all age groups. This is one more other finding which actually has been documented. So coming to epidemiology, PE is a psychosomatic disturbance. Men with PE have a lower frequency of sexual intercourse, higher levels of intercourse-related anxiety, higher levels of education, divorce, and presence of social phobia increase the risk of PE. Now you remember what I was trying to talk about. Majority of the psychiatric drugs what we use, whether it is antidepressants or antipsychotics, in fact, all of them can be judiciously utilized in this particular case. Men with controlled diabetes, hypertension, cardiac disease, hypercholesterolemia, and peripheral and central neuropathy, no association with PE. No report of association of PE with reduced quality of life, reduced sexual desire. This is one of the urological study, but we are all well aware it can affect in many ways. Coming to the theories, one important point documented is actually, in fact, I'll just run a little faster. This is one of the conditions where the biology documented is related to how our brain functions. We are all well aware receptors and areas in the brain which actually deal to the effector organs via what we basically call the spinal cord. Result of a sympathetic spinal cord reflex initiated by the genital and or cerebral erotic stimuli. Why we are talking about spinal cord reflex is even in those individuals who have spinal injuries and all like that, in fact, this can actually happen without much difficulty. Involves the sequential contraction of accessory sexual organs. Considerable initial voluntary control of emission progressively decreases until the point of ejaculatory inevitability. Ejection involves a sympathetic spinal cord reflex upon which there is little or no voluntary control this individual has. This is again diagrammatically explaining central mechanisms to peripheral. Almost all of these things are involved. What actually one should remember is actually emission and ejection. These are the two processes at that particular second level. In fact, individual has no control at all, even in the normal individual. So starting from higher centers to the lower centers, particularly the pudendal now S2, 4 are significantly involved in the whole process. Central areas, preoptic area, nucleus paragigantocellularis, cellularis, stria terminalis, and few of these things which have been documented, and a whole range of neurotransmitters which are, we as psychiatrists, we are extremely important to understand this particular process. So penile hypersensitivity for various reasons. In fact, one who has circumcision and somebody who doesn't have can make a whole lot of difference. Genetic predisposition, whether it is present, there is quite a bit of studies and data related to this. What actually one can say here is actually one of the most important neurotransmitters that has been implied is actually serotonin. And we are well aware, serotonin as a neurotransmitter, it acts like what we call endogenous schizophrenic, in the sense that in some individuals it is beneficial, in some individuals it is problematic, and in certain other individuals we won't know how actually it runs the whole show. The method is 5-HT1A facilitates sexual functioning. 5-HT1A lowers the threshold for ejaculation. This is one of the reasons why, in fact, any drug which acts at this particular level can hasten the process of ejaculation. 5-HT2 impairs the sexual function. 5-HT1B, 5-HT1C inhibits sexual behavior. So any drug which acts on some of these type of things may have a significant beneficial effects. 1B, 2B, 2C. In fact, all of these things have been implied as a very positive this thing. And when we are trying to talk about SSRIs, their role or problems are much more predominantly documented in case of women than in case of men. That is a different aspect altogether. Coming to 5-HT, low 5-HT neurotransmission, hyposensitivity of 5-HT2C receptors, ejaculatory threshold generically set at a lower point, hence ejaculates quickly with minimal stimulation. And the whole range of evidence is available once this depoxitin was introduced. It is one of the drug which actually, in fact, on-demand usage of SSRI only. 5-HT neurotransmission increases and activation of 5-HT2C, because of which delays the ejaculation. We did one very detailed review related to the drugs which are actually beneficial and all that. I'm not talking about premature ejaculation alone. Even for the ED and certain other things, actually, what one can actually present, what actually which was documented is, in the beginning itself, be clear, young individuals, newly married, and they're planning family, many of these individuals choose an antidepressant which is having less likely to create problems. Say, starting from bupropion, mirtazapam, agomelatine, vilazodone, and vertioxetine. Among all these things, agomelatine and vertioxetine have no reported, in fact, sexual side effects at all. And coming to these two drugs, in fact, vilazodone and vertioxetine, vilazodone is a partial agonist, but vertioxetine is a total agonist. That way, it may be much better drug actually for the starting the treatment when we are talking about ED. Why I am telling about this particular point is, say, paroxetine, which is used very commonly for control of premature ejaculation or other, say clomifene and other related things. If we increase the dose a little more, it can produce erectile dysfunction and a whole lot of things. Flubanserin, which was introduced in case of females, because see, one of the things what we were talking about was female sexuality in general is inhibitory. Flubanserin can actually reverse it because this agonistic property, what it has. Dopamine. Activation of nucleus accumbens and medial preoptic hypothalamic region by dopamine is the essential for sexual motivation. And this may be one of the major common area where premature ejaculation may happen. D1, D2 agonist facilitates erection, antipsychotic medications impair erection, but all said and done, if a small dose is used, they could be actually beneficial, and how and all of that will come 1 or 2 minutes later. Say any drug like even sedative, hypnotics, anything which actually goes via this GABA mechanism may have a beneficial effect on premature ejaculation. Antihistaminics may have a significant beneficial effect, in fact, on these individuals. So there are few things which are actually excitatory, few inhibitory. Each of these things can be utilized in general for the management of what we basically call premature ejaculation. Psychologically, whole range of theories are there, and one of the things is actually it talks about learning mechanisms and any situation where one of the common story is actually first time sex in the back of the car. He was in a hurry, and some particular speed which is actually established, it continues to go in that particular fashion. Body gets conditioned for this particular speed, and this is one it actually which leads to. And in simple terms, there are both positive and negative, biological and psychosocial theories. Combination of these things has to be kept in mind. How assessment can be done? There are quite a few scales are available now: premature ejaculation diagnostic tool and Arabic index premature ejaculation, and one from what we call Sandeep Grover and group from PGI Chandigarh. These are few scales which are available. I'll not go into too many details related to that. Coming to how actually this premature ejaculation can be treated. Therapeutic targets are better control over ejaculation, improvement of emotional intimacy, that leading to what we call better sexual satisfaction. Stress is one of the extremely important components, should almost always be kept in mind when we are trying to talk about, in fact, premature ejaculation. See, when sildenafil citrate was introduced, this comment I might have made quite a few times earlier, we all believed that all the problems of men and women is solved. Man could get erection and it will solve all the problems related to the sex. But a study was done about 2 years later for around 2000 plus couple, documented that hardly anything has changed. One important message at this particular point for the young people who are listening to my class: PDE5 inhibitors have no role to play in case of premature ejaculation unless it has some associated ED problem too. There are a whole range of drugs are available which actually include PDE5 inhibitors plus depoxitin together. But please remember that this has to be used specifically in certain given situation. But what actually Levine mentioned, in fact, Levine's one of the theories is actually not theory. Understanding is that desire disorders are the commonest, not PE. But many of the times, this emotional satisfaction which is missing, and this is what actually which leads to quite a bit of difficulty. And premature ejaculation is one of the major common problem, because a man, he thinks that sex means it is actually almost like hoisting the missile, but this is one of the things. Before she could be actually satisfied, he might have already lost the erection. So there are many methods are there. Keeping in mind that I'm trying to talk to psychiatrists in particular in this particular group, let me just focus on pharmacotherapy. Among pharmacotherapy, which are the drugs which can be used? Those which act at the central 5-HT level, all SSRIs, SNRIs, TCAs, and including what we call tramadol, can be useful. Other reasons, say psychological problem, depression, erectile dysfunction. In fact, these drugs, along with that, behavioral and psychological therapies, what can be, in fact, 1 or 2 minutes later, we'll come to that. Peripheral control of ejaculation, penile hypersensitivity, this can be blocked by many methodologies. One is at the local level, topical anesthetics, alpha blockers, surgical treatment, which very briefly I'll just mention in the later part. But all said and done, these anesthetic agents and other related things may bring down the sensitivity to an extent that, in fact, a person may not enjoy the whole process itself. There are actually studies to talk about, see, fluoxamine, sertraline, and some of the drugs, they can produce actually what we basically call almost like anesthesia-like effect. This is actually, it has been quoted by few of the studies. Some of the common drugs, SSRIs, what we use in our clinical practice, say, just I have focused on these 5 things, starting from sertraline, fluoxetine, paroxetine, fluoxamine, and placebo. Highest blocker was paroxetine. Paroxetine, if you are trying to use it for premature ejaculation, use it at a smaller dosage, maybe 12.5, 25, beyond which this paroxetine acts like a nitric oxide synthase inhibitor, because of which individual may land up with erectile dysfunction or insufficient erection and many other such problems. I am extremely comfortable with the usage of sertraline. fluoxetine has been found to be useful, but many people have a lot of difficulty as far as reaching orgasm and related things are concerned. Fluoxamine is supposed to be the least, but unfortunately, high degree of sedation and few of these type of things you need to keep it in mind when you are trying to talk about this. See, this is one of the extremely important diagram which talks about which drug can be used, where and how extent actually these are all effective as far as our premature ejaculation management is concerned. On-demand usage, in fact, Depoxytin is the drug which actually people have used. Coming to these drugs, what are the dosage? These are all available, and in fact, all of us are very much comfortable or familiar with this. Depoxytin should be used on demand. How? Another 1 minute later, I'll talk about depoxytin itself. There is a significant therapy gap. Off-label use of antidepressants, including paroxetine, sertraline, fluoxetine, citalopram, fluoxamine, and the serotonergic tricyclic clomipramine has revolutionized the approach to and treatment of PE. These drugs block axonal reuptake of serotonin from the synapse by 5-HT transporters, resulting in enhanced 5-HT neurotransmission, stimulation of postsynaptic membrane 5-HT2C receptors, and hence the ejaculatory delay. However, all of these things are off-label, in the sense, lack of an approved drug and total reliance on off-label treatment represents a substantial unmet treatment as far as PE is concerned. Depoxytin, available as 30 milligrams, 60 milligrams, in fact, has to be taken orally. Depoxytin is the first compound specifically developed for the treatment of PE. It's a potent SSRI, structurally similar to fluoxetine, but unfortunately, its duration half-life is only about 4 hours, because of which this is not used as an antidepressant at all. Whole range of studies are available which talk about IELT increase, control over ejaculation people get, and satisfaction in sexual intercourse. These are all studies which are done on what we basically call depoxytin specifically. It is not used for children below 18 years, and very few contraindications, but all said and done, this can be used very comfortably. Swallowed whole to avoid the bitter taste. Tablets be taken with at least 1 full glass of water. Prior medical history focusing on past orthostatic events and orthostatic tests must be done. Recommended starting dose for all patients, 30 milligram, and if not responding, go up to 60 milligrams. These are all data available related to which all things can be done. Depoxytin, topical anesthetics, SSRI, clomipramine, in fact, have been indicated as a first-line treatment in almost all the guidelines which are actually available. All the other things, depending upon type of PE, in fact, one actually need to look into. There are a range of natural methods people have suggested. What it actually means is diverting one's attention, chewing something, and many other such this thing, thinking of something else. These things can divert and the individual may get what we basically call relief. This is what actually people have documented. And if you try to look at the literature that is available, there are plenty of methods available. Actually, people have documented which says that, in fact, these are all easy to follow. Non-pharmacological treatments, specifically, in fact, psychodynamic approaches, behavioral therapies, supportive therapies, self-help techniques, extensive training programs related to how actually one can relax the deep muscles and mechanical aids. So, non-pharmacological treatment techniques, they are in plenty. This have been actually described. Some people need psychosexual therapy. What actually it means is those people who have a significant problem, those who have not responded well or in fact not felt adequate to benefit with some of the pharmacological and other methodologies, psychosexual therapy should be combined. So this becomes one of the important line for the management of premature ejaculation. So one of the psychosexual therapy, what we talk about is actually the sunset focus. And these are all structured programs, and we are all well aware. It is actually that involves improving communication. Second, utilizes the touch as important step because the female sexuality in general depends on this particular thing, and it is actually what we call oxytocin dependent. That means including the relationship, bonding, and lot many other things are extremely important steps one has to follow. Systematic desensitization, in fact, starting from the least anxiety to significant one. And these are all the few steps people have documented. I'll not go into details because they're all discussed in greater detail earlier in Thursday musings. Dr. Raj has spoken about sex therapy in general and female sexual dysfunctions. Anita Sham had spoken earlier. Sensate focus without genital contact, with genital contact, together, one caressing other, genital contact with simultaneous caresses, vaginal containment movement. This is actually the sensate focus it runs. And when we are trying to talk about premature ejaculation, non-demand sexual stimulation, and one of the actually positions suggested by Master Johnsons, because this works out to be convenient, and two important procedures which have been documented. One is actually the squeeze technique, antero-posteriorly, in fact, giving the pressure after bringing about some particular level of stimulation. That way he can learn the mastery over, in fact, getting and losing erection. Stop-start techniques. It could be, in fact, first and then squeeze technique subsequently. The squeeze technique at the coronal level or at the basal level. These are all few of the things which actually people have documented. People have found a significant benefit with the Kegel exercises, even in case of men. See, as far as the men are concerned, there are many things actually possible what can act at a particular point. But when we are trying to talk about couple therapy, the female, in fact, whole lot of erosion zones and whole body is responsive, and how actually one should go about. This is one of the whole process one has to learn this particular skill in management. And almost all techniques of sensate focus talk about ultimately female superior position, because of which she can have control. Insertion, no movement, slow movements. That way she can help train the man how actually one can go about. Men usually the top position, they land up with early ejaculation. This has been actually documented in many of the studies. So there are a range of psychological theories which are available. Just to mention, selective penile dorsal neurotomy to, in fact, for PE cryosurgery and what we call dorsal penile nerves, in fact, stimulation by pulse radio frequency to, in fact, to reduce their what we call sensitivity. All of these things are there, and they are not my concerns at this particular point. To conclude, some important carry-home messages one should be well aware of when we are trying to talk about premature ejaculation. What are these things? One is primary and secondary. This determines what type of premature ejaculation individual is presenting, how actually one should go about. After establishing few of the things what we have already mentioned, see, for example, PE secondary to ED or medical condition, manage the primary cause. Acquired PE and lifelong PE, the whole range of drugs to behavioral therapies. And what we talk about variable and subjective PE is reassurance, education, psychotherapy, behavioral therapy. And in fact, this is one of the well-established, what we call line of management, what actually one should follow. So acquired and primary, you bring it to one group, and what we basically call variable PE and subject PE as another different category. Why all these things is necessary is, in fact, in couple therapy, there is another person who is called partner. It could be wife or a partner, that her concerns are actually necessary to be. So one important message is communication and sex. It is not only between husband and wife what we are trying to talk about. The doctor should be able to ask a question. Do you have any sexual concerns to talk about? Many of the times, many people will come forward and they'll talk about it. You, without asking about 10% of the people, if you are concerned in this particular area, they are likely to talk. You just ask only one question. The number of people who come forward with problems is actually increases by 50%. And there is an orgasmic gap. This orgasm gap or orgasm inequality is defined as the difference in orgasms and sexual satisfaction by partners. So there is a wide gap between these two. And in one of this Journal of Psychosexual Health article by Adarsh Tripathi from Lucknow, the female orgasm gap, translating contemporary scientific understanding and socio-cultural movement into clinical wisdom, has been dealt in a great detail in this review article. What is the point? See, as far as the man is concerned, it is the linear process wherein, say, desire, arousal, orgasm, and resolution. And this is what called Rosemary Basson's circular model, very specifically applicable to females, wherein she can be triggered, it can be altered, it can be affected at any point for a whole range of reasons. And this is one of the reasons why extremely important that men and women, we are literally different, and one should be well aware of the point of difference. And this is from the clinics of North America. It talks about fantasy alone may be sufficient only in small number of individuals, particularly females. Intercourse situation, around 29 to 32% of women can reach orgasm. And the whole range of processes for necessary for arousal and for orgasm in case of females is by touch, touch, and touch alone. And it has been documented that by vibrator stimulation, it is possible for the woman to reach orgasm. And in case of premature ejaculation treatment, this is extremely important to remember how to combine these two. I'll come 1 minute later. One important point is actually too much of expectation, the whole psychotherapy related to. I thought there is one small video I'll just play. Some problem has happened. Why videos are not playing? In fact, Warren Buffett's advice in this video, he talks about how actually, in fact, we have to just train them to reduce the expectation. We are all well aware men take about 5.4 minutes. That's what actually we had mentioned in one of the earlier studies. Women during masturbation, 8 minutes. Women during sex, they need extra time, 14 minutes. So a man can be trained how actually to masturbate a woman. In fact, that can make a whole lot of difference. And this is extremely important to be kept in mind. Oh. And one of the techniques which has been actually people have spoken about is actually coital alignment technique, wherein how precisely one can flow along with, which can actually bring about stimulation of what we call G-spot and things like that. And guided masturbation as one of the important therapy for female problems. And after the ejaculation, many men just turn around and sleep. This is actually which makes the whole situation worse. A man is having one penis and there are about 10 vibrators. That means 5 fingers in one hand and another 5 fingers. Each of this can be utilized. And now sex toys as one of the important methods of treatment. And now there are actually AI-generated knowledge available, how much to stimulate, how to go about, and lot many things. In fact, in the coming days, there may be revolution in this particular area possible. In conclusion, what I can say is, premature ejaculation is extremely common problem. One should almost always keep this particular point in mind when we are treating individuals. Be proactive, collect information, and that way you'll be contributing in a great way for sustaining the relationship and bringing about man-woman magic. There are clinical practice guidelines available from our Indian Psychiatric Society. In fact, this is along with Dr. Ajit Avasti, Sandeep Grover, the sexual dysfunctions were covered by us. IPS textbook of sexuality and sexual medicine. Journal of Psychosexual Health covers in great detail many of these type of things. And in addition, one of the book which is getting ready, most probably I should be able to by the year end, Embracing Heroes, Navigating Intimacy, Sensuality and Touch, how one should go about. This is one of the book which is getting ready. Thank you very, very much for very patient sharing, and we'll try to spend some time on responding to the questions.
Thank you so much, sir. Thank you so much. You made us wiser in these 45 minutes. We are opening now for question answer and opening remarks from chairpersons first. If there are any opening remarks to the chairpersons.
No, sir, we can continue with the questions.
Shobit, can you help take the questions in the chat box? Vishal bhai?
Yeah, please.
Sir, very comprehensive presentation as usual, sir. It has made us revisit our MBBS days, sir. Sir, so a lot of pharmacological based scenario queries are there. Sir, specifically, so one of the questions which is there that so you have touched it in acquired PME. Was there any specific age with or aging affects PME, sir?
Okay, 1 minute. I am also just opening. Okay, what is the question again? Tell me again.
Aging, whether sir, like aging would affect premature
See,
ejaculation.
one of the, in the natural course, what one can look at is actually premature ejaculation is primarily the problem of young people. As and as in individual ages, automatically it slows down and it may get corrected on its own. This is one of the important points. Unfortunately, what happens is among the older individuals where infrequent sex, this is what leads to the early ejaculation. If it is consistently present, persisting, then using a small dose, which can be corrected. One of the common understanding is actually as and as individual ages, it becomes better. It gets corrected on its own. This is.
And sir, if supposedly a patient would come to, within PME, a young patient, so just recently married, and sir, any investigations we need to do as a part of any protocol, or so you shared that it poorly correlates with vascular disorders and all. So, sir, any specific protocol in that sense, or will immediately
Right.
come
So,
to?
see, the whole range of protocols are available when you are trying to talk about desire disorders,
Yes, sir.
erectile dysfunction, and female sexual responsiveness are concerned. Premature ejaculation, let me put it in very simple terms. We do still do certain tests, not because of anything, but many people won't get convinced. They want something to be documented. It is only from that particular angle. For all practical purposes, if it is a premature ejaculation alone, hardly any worthwhile investigations are necessary. He is quite here, healthy, except that in simple terms, it is an anxiety related responsiveness, what actually, among many other things, this is also one of them.
Right, sir. Right, sir. Uh, b- Sir, specifically in context of nutraceuticals, like sir, molecules like Shilajit, Ashwagandha, sir, do we have any subsequently data regarding its efficacy in PME, sir?
Okay. See, the point here is actually PE means this particular individual is very easy to get aroused. He has no difficulty as far as erection is concerned. And many of these things, starting from Ashwagandha to Shatavari and a lot many other things what we talk about, they're all absolutely not necessary in this individual. Some amount of anxiolytic to mood improvement processes for which actually people have documented this is being actually useful. But there are some Ayurvedic preparations, but unfortunately, whether I can quote the names here or not. Say there are few things which are actually a combination of stimulants, a combination of like an antidepressant effect to a lot many other things. So it is a what we call one shot for all problems. That type of things are available, which can be beneficial to some extent because both inhibitory and stimulatory drugs have been actually added in that whole combination. How much it is useful and all, we don't know. But if any one of you are interested, Bablova is one of the article which has been published in July issue of Journal of Psychosexual Health. It is a very detailed 28-page article covering many of these what we call phytonutrients, each one how it actually acts and where to what extent each of these things can be utilized. Unfortunately, the drugs which are available in the market are multiple combinations and permutations because of which, of course, one is, this is a scientific program, I don't want to label the names, but all said and done, individually how each one works, in fact, there are data available. But any drug which is having antidepressant effect, whether it is we are talking about phytonutrients or pharmaceutical agent, they are having beneficial effect as far as premature ejaculation is concerned.
Sir, one related question, sir, because when we design treatment for OCD, so we sir take care of the molecules which have serotonergic effects, like clonazepam in terms of benzodiazepine, trazonil if the patient is complaining of insomnia. So can similar approach be taken up, sir, in context of PME, sir?
In case of OCD people,
Sir, like in so when we design the augmentation strategy, so every molecule with some serotonergic activity, even antihypertensives, pindolol, timolol. So whether the similar strategy can be taken up for PME, because again, because the serotonergic system involved, as you said, sir.
See, the point is in this particular fashion. See, when we say serotonergic agents, for all practical purposes, they can produce difficulty. We are all well aware.
Yes, sir.
Those which can bring about sufficient erection and positive effect for erection, those which act on dopamine mechanism. And when you are trying to talk about SSRIs, those which act on 5-HT1A mechanism, they are all beneficial. Those which act on 5-HT, 1B, 1C, 2C and all, no, they're all actually can create difficulty, problems. Say, take an example, even a simple drug like venlafaxine.
Yes.
It has been found to be quite useful for premature ejaculation. But when we want to actually premature, in fact, erection problem should not be present at all means we go for desvenlafaxine. Even little modification in the molecular effect, it can actually bring about remarkable changes. SNRIs and all what we talk about. And among SNRIs, whether it is a 25%, 50%, 75% serotonergic property, another about 25%, 50%, 75% dopaminergic property. So it can make so much of difference as far as this particular molecule is concerned. So the important message here is any drug. What we know at present is actually with one or two very specific drugs, paroxetine, what I was trying to talk about. Paroxetine has been found to be as what we call nitric oxide synthase inhibitor, because of which very commonly associated the problem of ED among these individuals. But this has not been reported with other molecules. Say when we are talking about, say, sertraline, as I told you, I am very comfortable with sertraline. Many people respond to 25 milligrams, 50 milligrams, and a small number of individuals, around 100 milligrams of sertraline, they respond extremely well. And compared to what we basically call on-demand drug, majority of these individuals are anxious, depressed, and this is one of the reasons why our armamentarium of antidepressants, which actually having the longer duration of action, they are the best drugs for the treatment of premature ejaculation also. Because somebody is very anxious and all that, depoxetin only acts for a short length of time, is totally different from. That means only a symptom management. If you are trying to manage the whole psychopathology, the better drug would be other antidepressants which are having beneficial effect. Overall, actually, they try to attend to the individual's problem.
Sir, series of questions of depoxetin as in the chat box, sir. Sir, depoxetin, can it be given daily, sir?
It can be given daily.
Yeah.
Sir,
It can be given along with paroxetine or other antidepressants also.
that is one of the questions, sir. And
Yeah.
so propanol, if like, because it will work in anxiety, so propanol.
See, for example, beta blockers and beta adrenergic activity, any beta blocker can slow down what we basically call the erection. So this is also useful even in case of premature ejaculation also. What I am trying to tell, any drug which we give for anxiety alleviation, whether we are trying to talk about a simple sedative, we are trying to talk about an antidepressant, or whether we are attending to
Beta blocker.
each of these things are beneficial only.
Right, sir. So supposedly, sir, there is a scenario, patient doesn't respond to combination of paroxetine and depoxetin, sir. Then how to go about it? And therapy, psychotherapy or sex therapy?
The whole problem is with the drugs alone, almost around 50 to 60% of the individuals we can actually succeed. And we have no data related to the partner, whether she is happy with whatever improvement what he got, but at least this individual will come and tell you. And many of the times we are treating many of these individuals pharmacologically, not because of anything. They don't come with the partner. He has come alone. He has been evaluated and there is no other cause to explain. And psychological sophistication is not there. And this is where actually this drugs pharmacotherapy actually works. Unfortunately, many married women are not happy with their husbands, not because of anything, but many husbands are not aware of what are the techniques that need to be used for keeping the woman happy. That's where the whole psychotherapeutic techniques come into the picture. A little bit of education, little bit of spending time, little bit of understanding her needs. See, instead of once immediately ejaculation turns around and slips off, rather than that, see, a little bit of time he can spare for her. That's all actually what is necessary. A little bit of education too, where necessary, a proper treatment one can. Let me tell you another. Earlier days, we never used to get women actually complaining about sexual problems. But many women nowadays, we get actually with very specific problem, and they are disappointed with men in general, because not only husband, quite a few other partners also. In fact, all men are totally hopeless. This is actually one of the version by many people. Not because of anything, but many people are not trained how the female physiology works, female psychology, and how this particular thing should be actually. Just like we talk about foreplay, this is what is called as afterplay, which is extremely important component to be kept in mind.
Yes, sir.
Differences.
There are, of course, there is another one small comment. There are people actually who suggest he should have sex and he has once ejaculated, spend a lot of time with the partner to stimulate her to the best extent possible. And for that, training the woman in masturbation, making them understand what is and how her body responds and psychologically it actually works. These are the few of the things which actually people have utilized.
So paroxysm as an SOS? I'm not sure. So paroxysm as an SOS.
People have used as an SOS, but many of the times, many of these individuals are anxious and depressed individuals. Regular usage is actually what is advised. That is having the maximum beneficial effect.
So what are the usual comorbidities you see with PME? Usually comorbid conditions.
Very rarely we come across any other comorbid condition except for anxiety.
Yeah.
And as we were trying to talk about, say for example, diabetics, other individuals and presenting with the problem, there is an infrequency of sex and which leads to the early ejaculation, and that should not be labeled as premature ejaculation or early ejaculation as a diagnostic terminology. It is only that little modification what need to be done in those individuals.
Sir,
Do you use
There
tramadol?
was a
also?
question.
I have
Sorry.
not used tramadol for premature ejaculation that way, but this is very commonly recommended by quite a few people.
At what dose? At which dose?
Which one? Tramadol?
Yeah.
See, any benzodiazepine which you are comfortable and what he is comfortable. Many of the times I give them alprazolam, maybe 0.5 mg and 1 milligram for a short while, and antidepressants we continue. That those with actually a little bit of anxiolytic property associated with that. Say what is one of the classical thing is actually sertraline itself, or any of the other antidepressants could be good enough, fluoxamine. So the point here is sometimes anxiolytics are used not because of anything. Anxiolytics in general, they can reduce his anxiety level. His reaction and responsiveness to ejaculation can come down. So all of these things are beneficial. So instead of
Tramadol would be the opioid one.
see, anything which can bring about sedation has found to be actually
Okay, anything has calming effect.
Why Dr. Manvi's question is also more important is because in opioid withdrawal we'll see a lot of premature ejaculation. Sir.
So any opioid, but of course we don't recommend opioids in general, not because of anything. The whole range of potential risks actually they carry.
One question:
suppose,
in how much time you see the clinical benefit with paroxetine? Actually, you told ki you mostly start with the low dose paroxetine. That is very important, 12.5. Rather than jumping to 25, it is always better to start with 12.5. So how do you counsel your patient ki in how many days you will be seeing the effect of paroxetine on him?
Many people may respond. In fact, it all depends upon the problem, how long this particular problem, and whether other associated issues are present. Many people start feeling a beneficial effect even with one dose or two doses at the end of maybe about 1 day, 2 days, 3 days, 4 days. And some of these individuals we need to recommend as a long-term treatment also. Just like antidepressants we use from our psychiatric practice point of view, a lower dosage for a long term. If significant anxiety, depression present, maybe little medium level dosage for the long-term treatment only. In fact, many of the times this is in terms of 6 months, 1 year, 2 years. Very comfortably, people are doing quite well with that particular methodology.
Just as a non-psychiatrist, I'm asking you, like, is there anything like if you're giving somebody paroxetine for a period of 1 year, then can he suddenly withdraw the medicine, or like he has to like gradually something? Is
any antidepressant we suggest it should be reduced and then taken off. This rule is applicable to all antidepressant for all practical purposes.
Yes.
See, there are
At
some
any
drugs
dose,
like,
even at 12.5 also.
yes,
Yeah,
12.5 also. Reduce it by a half, maybe quarter, and then take it off that way.
So, sir, if we give SSRI and suppose ED is worsening, then what to do?
See, but this is one of the reasons why many of these depoxitin tablets are available with PDE5 inhibitors combination also.
Yes.
This is one of
Yeah.
the important.
Combination comes, sir. Yes.
And you have to make use of the PDE5 inhibitors even separately or together. When you may not like combination means, say something like any of these drugs, either tadalafil or this thing,
Sildenafil.
sildenafil, together one can actually comfortably, one can continue.
How often, as a psychiatrist, you use local anesthetic creams or a spray?
Very,
Because
very,
penile hypersensitivity
Very
is also
very,
important in these cases.
see, I usually go with an idea that all these problems are relationship problems, and we spend a lot of time training them in psychotherapeutic techniques and sunset focus exercises and other related things, what we actually very strongly recommend. See, many people feel not comfortable either using even condom itself. Condom can reduce premature ejaculation, but many people feel that whole sensation is actually missing in the process. And this local anesthesia can create worst possible scenario in the sense that you may not have that particular sensation at all, which creates a difficulty. There are very few individuals where we have used together some of these type of things, but there was no significant necessity at all in my clinical practice, what I have seen.
So that
Sir, even in
compromise on
sir,
the
even in your
sensation.
past, past lectures also, you've really almost focused on improving the relationship between the couple. Always, I think you've always done that.
Sadly.
Sir,
This
any
is
role of
like-
exercise, sir? Exercise, the role of exercise.
See, role of exercise, I'll tell you, put it in very simple terms. This is spoken in terms of what we call ED. Take an example.
Yes, sir.
See, one of the most important molecule among many other things, say, for example, if somebody does exercise, whether endorphins changes, whether it affects dopamine, whether it affects other neurotransmitter mechanisms. But there's a whole lot of studies are available on DHEA, dihydroxyethylamine. See, dihydroxyethylamine is a hormone. It is a parent hormone for all the things. Say, whether you are talking about testosterone, estrogen, or many of the other things, actually. This is one of the most common. And one study I can quote at this particular point. If a person is doing about 30 minutes of medium level exercise, the DHEA level increases by about 2 to 3 times at the end of third to fourth week. What it means is, say, after doing exercise, we feel happy, we feel confident, we feel better. Many things are involved. This DHEA level has been as one of the parameters people have documented. So all lifestyle issues are extremely important issues necessary here. This is we are trying to talk about what we call erectile for erections are concerned. See, as far as premature ejaculation concerned, he may be a Pailan, but he ejaculates very fast. No, you got the point. That is a totally different area. The exercise is important as a lifestyle issue for all problems. But premature ejaculation alone can be controlled by exercise. It has not been documented that.
Right.
So, as we see in our clinical practices, more of young male, unmarried who have sexual exposures, they come to us and they focus on non-pharmacological measures like Kegels exercise. How often should we advocate for this thing? And reassurance regarding the improvement with this Kegels exercise. How much should we provide to the individuals who come to us, usually unmarried male, who are not into marriage, occasionally they have
Unmarried but in
faced these things.
relationship, unmarried but not in relationship. These are the 2 points. Which one you need to be answered?
The unmarried, sir, unmarried into occasional relationships, like they.
So, see, let me tell you, we have done, in fact, my PhD was on Dhat syndrome. See, many of the time what happens, people have a whole range of myths and misconceptions related to ejaculation, semen, it is a precious cargo, losing it means loses vitality and other related things. And those who are actually doing masturbation, and once they are get into this idea that it is actually something wrong, one should not do, he is actually inbuilt for premature ejaculation with the partner. Premature ejaculation, inverted comma. This is not called premature ejaculation, but early ejaculation is one of the common thing that will happen. Not because of anything, but because the whole body's responsiveness is trying to control, which is not possible. Seminal vesicles are totally full with and loaded, and this is one of the reasons, even whether he is straining it, passing stools or dreams in the night, or more particularly if he is there with a partner, the amount of stimulation is so high that he will ejaculate early. Majority of the individuals will land up with this particular difficulty. There are, for some of these people, some of the natural way of controlling, say masturbate and then go to the partner. No, you got the point? That way it can reduce some extent. But most important step is actually making them understand that avoiding masturbation creates more problem. This is likely to be the difficulty which actually they are going to land up. These are a few counseling and other related things what we need to do. Some of these people are highly anxious also, where sertraline, paroxetine, or any of these antidepressants can be very comfortably used.
Yes, sir. Thank you, sir.
So there's a question. Somebody is, I think, working in Afghanistan. I have many. He has many cases, young to old, of women, and women, according to him, are more proactive there. But patients are not responding to Viagra or Depoxetine. Psychotherapy is ruled out there. SSRIs and anti-anxiety medication is also ruled out. So what can be done in such cases?
I see the problem in Afghanistan, as we understand, say what our limited knowledge, because that's what actually we are seeing in TV and all of that. See, unfortunately, there is no other avenue for release mechanisms for ladies given in many of these Muslim countries. I can tell my experience. Very recently, I was there in Abu Dhabi and quite a few other, even some of these very fashionable ladies, but unfortunately, they are seen only in the malls some extent, and there is no other entertainment or focus available. And the whole issue here is actually this man has to perform and has to satisfy them, because that is the only, I think, pleasure-related activity that may be permitted. This is very difficult for any man actually to do it. What one can suggest is actually, in a given situation like that, whether that is the area of focus, whether in fact whether there is only one wife or many wives, that may get distributed. In relation to this, I'll tell you one small story in my clinical practice. I have this young individual, somewhere around 35 years, a Malayali, at the end of the road where I practice. This fellow came and told me, sir, I'm having premature ejaculation and erectile dysfunction. I went into a little more detail. So this fellow is having an affair with a lady. So he closes the shop at 7 o'clock, goes to her house, tries to have sex, early ejaculation. Then about an hour later, he goes to wife. After dinner, he tries to perform sex. It is not possible to perform. A little internet savvy, and he was telling, sir, I'm having both premature ejaculation and
Delayed ejaculation.
What I did, only changing the timetable. I told him after he closes the shop, he will go straight home. He could have dinner and he could perform, and you can visit his girlfriend while coming in the morning. Premature ejaculation to a great extent came under control. You got the point. It may be little common sense you have to make use of,
Yes.
and explain to them how
Yes,
to.
no medication will work there. Common sense is required. True.
Of course, this Afghanistan difficulty, because if women are given different methods to follow, in fact, things will work. And many of the times, this religiously speaking, masturbation may be considered as a sin or
Sin. Yes.
This is one more other thing which only man has to satisfy, even in only in intercourse situation. It is not a very terrible situation. Actually.
That may also be cultural thing, that if he is not doing it with her every day, he might lose her, or he might go away somewhere else. That insecurity may also be there, part of the culture.
So the history and context becomes very important. So that is what. So you're trying to. Sir, an interesting question is about TSC, and now CBD has come for epilepsy, sir.
Which one?
So TSC and CBD, sir, their role in premature ejaculation.
I didn't catch the question.
So CBD oil.
The oil and TSC.
Oh. See, the whole issue, we really don't know. There are a lot of oils are available, starting from Japanese oil to many things many people recommend. Our experience related to that is actually very limited.
Awesome.
But the whole issue here is only this much. There are some which contain anesthetic agent, some which contains stimulatory agents. See, one of our editorial in July issue is, along with Chitran and Andrade, the local application of sildenafil citrate on vagina and how stimulation can be brought about. In the similar fashion, there are plenty of different preparations are available now. The sildenafil citrate in the form of a gel which can be applied locally, and it can bring about vasodilation and stimulation and things in that particular fashion. So primarily these things, whether an anesthetic is present or not, whether to reduce or increase, depending upon, again, the context and case, one need to actually modify.
Right. Right.
Thank you, sir. I think we have taken all the questions. I think we should start winding up. It's already 9:30.
All the relevant questions, because there are many questions which are off the topic, such as I think we can omit this. We can only but there is one in chronic alcoholics after de-addiction complaining of PMA and ED. The treatment approach is same there or any changes?
See, the whole issue, we have very clear data related to ED, desire disorders, among these individuals. When we are talking, the whole important point is actually somebody was talking about opioids. Very commonly, the amount of stimulation opioids can give can never be possible with any woman, however beautiful and extraordinary as far as this earth is concerned. Alcohol. Many of these people get into this thing because they feel this is more rewarding and good. Unfortunately, all of them produce effect on different systems and problem. There is a significant gap, and once gap is there and he tries to perform, is automatically he is likely to land up with early ejaculation. So this should not be labeled as premature ejaculation diagnostic terminology. This should be treated as a symptom which is associated. So maybe once he gets back into this is totally detoxified, free from, and get into it, is a little bit of time. See, our sex is actually that it is use or lose. Somebody has been totally off for a whole range of reasons, and suddenly he wants it to get back into that, means it is not possible that way. So it is not the primary ejaculation as a problem, but ED and desire disorders are the primary problems there. Once that is corrected, the ejaculation also, once frequency increases and regular sexual activity happens, and some of the drugs like antidepressants and other things can be judiciously used, many of these people can be corrected very easily.
Sir, how effective is on demand duloxetine, and what are the doses that you have given?
Many of these pharma companies which market, what they come and tell is actually, in fact, this drug has not made such a major difference in Indian context. In many of the other countries, this is used very regularly, but somehow in India, there are two drugs. One is sildenafil citrate, the other one is duloxetine. Somehow it has not stood the test of time as far as Indian context is concerned. Why, we don't know. See, even starting from some of these multinational companies to others, they go to the urologist not because of anything. They are more comfortable writing than we psychiatrists. Hardly anybody comes and meets you or me because we don't write. That's what actually they say. So the issue is related to the problem in this particular fashion.
Sir, one HLA injection, sir. Have you used HLA injection?
Which one?
HLA. Hyaluronic, I think.
What's that?
Okay. In fact, again, none of these drugs are found to be effective for premature ejaculation that particular way, except that, say, for example, platelet-rich concentration of those things, hyaluronidase, and quite a few other the toxin, botulinum toxin. Many of these things people have tried. But physiologically speaking, or the theoretical and practical understanding what we have, they are not likely to benefit in a very significant way.
Sir, I think we should start winding up now. Sir, a request. Only 4 or 5 points. How to treat manage PME. Only three to 5 points. Just points.
Okay. Premature ejaculation belongs to psychiatrist. We should show interest, make inquiry proactively, and that is one important point. Second, you cannot treat PE, in fact, PE as one of the purely standalone problem. Many of the times it is a relationship problem. What actually, say for example, I am having premature ejaculation with one lady and no premature ejaculation with another lady, that means it is a relationship problem, it is not premature ejaculation. The third one, there is no documented major systemic disorders which talks about premature ejaculation. That means extraordinary investigations, protocols, none of those things are necessary as far as premature ejaculation diagnosis is concerned. If somebody is having only premature ejaculation, you can treat him like any other psychiatric case, what you treat, purely psychological methodologies. The fourth one, we are all absolutely comfortable with antidepressants. In any of the antidepressants, what we are using at a smaller dosage, they are all effective, though they are off-label indications. Before using whatever antidepressant, be aware of pharmacokinetics and the potency of these molecules, in the sense that some of them can produce iatrogenically ED and other desire problems in some individuals. Be aware of this particular point. So when you are choosing antidepressant, particularly young individuals, newly married, who want to establish this thing or who are concerned about sexual issues, start them with antidepressants which are least likely to produce erectile dysfunction. Any antidepressant could be good enough for all practical purposes.
Thank you so much, sir. We are so thankful to you. Over to chairpersons for the remarks, and then to Tofan sir to finally wind up the session. Any chairpersons, please.
Thank you, sir. Thank you, the team. Thank you, sir, for elaborating on this PME. It is not a one-sided approach. There should be an holistic approach that we understood from this presentation. It's always good to hear from you and learn from you. I thank organizers. I thank everyone over here for this.
Dr. Sharath had raised the hand actually, no?
About this question only.
This
About this question. HLA injection. I asked for this.
So I thank everyone. I thank sir for this presentation. With this, I ask if my co-chair has anything to say regarding this.
Thank you, sir. It was a wonderful session. Like at least at my personal level, I've learned a lot, and maybe I'll try to treat my patients better and refer them to psychiatrist early.
Thank you, Manmeet. I am there for you. Thank you. Tofan sir, over to you.
Thank you all the participants, and thanks Dr. Rao for this enriching enlightenment. There could have been a lot more discussion, but I don't want to come the way of the conclusion of this. But there could be a lot of discussions. We'll reserve it for personal discussion or in the next meeting. And thanks all the moderators. Thanks our chairpersons, Dr. Manmeet Singh and Dr. Abrar.
Thank you, sir.
All the participants are welcome. Thanks, Tarent, and thanks, Thirst Musing team.
Sir, we had nearly... Yes, sir.
Yeah, Polo?
Sir, we had nearly 200 participants, 197 peak, and
yes.
more than 250 logins today.
That's nice. हमको extend करें?
It only shows you should have every month one program.
Yeah. We are hearing you, sir.
Enriched.
So there was a slow start, but it was maintained.